This is caused by infection, bacterial infection, can be due to chemicals, virus. Um, it's typically found primarily in children. Um, some of the features of this include anemia, thrombocytopenia, kidney injury, central nervous systems. Um, this is caused by bacteria E. coli, often typically from eating undercooked meat. The bacteria will infect the digestive tract and release toxins that will destroy red blood cells. Damaged red blood cells can lodge in blood vessels in the kidneys, blocking them and preventing blood flow to the nephron, which causes acute renal failure, ARF. Also, you may see some more signs and symptoms would be proteinuria, hematuria, BUN and creatinine levels would be elevated. Hemoglobin, hematocrit would be decreased. Interventions, if the child is anuric, cannot void at all, maybe dialysis, peritoneal dialysis, or hemo. Strict monitoring of fluids. Fluid restriction may also be prescribed. Also, we want to make sure we're, to prevent any type of infections, a lot of hand hygiene, adequate nutrition. Other treatments may include administration of red red blood cells, blood products to treat the anemia. Your slide shows plasma. Again, may be needed as well. That's, of course, a blood product as well. Next up, urinary retention. We've already talked about this some, but you're going to see it a lot, so it bears repeating. Urinary retention, involuntary accumulation of urine in the bladder from loss of muscle tone, occurs as a result of anesthesia, opioid analgesics, and can appear anywhere from 6 to 8 hours after surgery. And so with the bladder retention, you may see that they void some, but not all. They may have, of course, will show as a distended bladder. The best way to check for this is bladder scan to see how much is still holding in the bladder. Of course, very common as well in post-op patients. If this is a post-op patient, we want to make sure that they void within that first 8 hours. If they haven't, bladder scan them to see, offer to get them up, sit them on the toilet. Some people, they just need to get up and sit on a toilet. So some potential interventions there. Also, if they're able to get up and walk around, that helps wake everything up after surgery. May also be helpful. Elderly people, keeping them on a bladder training program, taking them to the bathroom every 2 hours, whether they say they need to or not. You still take them, let them sit there, and they may be able to void as well. Also, bladder urinary retention can be acute or chronic. Again, like I said, elderly people have this problem as well. Could also be due to a blockage, possible stone, your swelling of the urethra due to infection or sexually transmitted infection. Also, remember your medications. We talked about this earlier. Antihistamines, Benadryl, can cause some urinary retention. Antispasmodics like Detrol, or antidepressants, tricyclics such as Elavil. Also, we want to consider BPH again. I know we have talked about BPH, but quite common problem happens to men typically more likely after the age of 60, and even later in life than that. Seen some men not being diagnosed until they're well into their 70s and 80s. So, let's see. Some of the signs and symptoms, if this is due to BPH, would be the urinary urgency and frequency. Get up several times through the night to pee. That's nocturia. They may have some hematuria as well. Hesitancy, difficulty starting a urine stream as well. Nursing interventions can include, increase in fluid intake, depends on the physician. 2,000 to 3,000 may be what is suggested by the physician. They may also occasionally have to self-cath to drain the bladder. Try to avoid some of the medications that can cause urinary retention that we've already talked about. They can take medication we talked about earlier to shrink the prostate. Those meds again were tamsulosin, finasteride, and dutasteride. Trade names Avodart, Proscar, and Flomax. Also, if you are pregnant or in childbearing years, women need to handle these medications with gloves only. Let's see. All right, next up. Here's that picture again of the hyperplasia, the BPH, and the prostate gland itself. So you can see very much so how they have a hard time voiding with their prostate enlarged about probably 3 times what a normal would be. Okay, acute kidney injury. Acute kidney injury, rapid loss of kidney function due to cell damage, usually occurs abruptly, can be reversible. Prognosis depends on the cause and the condition of the client. Can be caused by dehydration, decreased blood flow, infection, obstruction, or some type of injury. There are phases with the acute kidney injury. Oliguric phase, where the BUN and creatinine and serum creatinine are elevated. Decreased urine speck gravity, hyperkalemia you may see, decreased sodium level, hypocalcemia, hyperphosphatemia, The diuretic phase, gradually decline in the BUN and serum creatinine, continued low creatinine clearance with improving glomerular filtration rate, may have hypokalemia, hyponatremia, hypovolemia. Also in the recovery phase, we'll see increased glomerular filtration rate, milliliters per minute, stabilization or decline in BUN and creatinine, getting toward a more normal level. Interventions, and this can be, these acute kidney injuries can be from a fall and injury, sports related or non-sports related. Some nursing interventions will be daily weight monitoring, BUN, creatinine, urinalysis. Be watching for acidosis that can occur. Monitor protein levels in the diet. Also protein in the proteinuria, hematuria. Monitor for signs and symptoms of infection. Diet for this would be low to moderate protein, high carb, and of course low sodium. Restrict potassium and sodium. If it does not turn around quickly, they may be on dialysis due to this. Okay. All right. Last but not least, polycystic kidney disease. All right, polycystic kidney disease, cyst formation, and causes hypertrophy of the kidney that causes the cyst to rupture. Of course, with the rupture, there's infection, scar tissue, damage to the nephrons. There's no specific treatment to stop the progress of the destructive cysts. Ultimate result of the disease is chronic kidney disease. There are two different types, infantile, and also the infantile is an inherited autosomal recessive trait that results in death of the infant within a few months after birth. Adult polycystic disease is the second type. It's an autosomal dominant trait that manifests between the ages of 30 and 40 and results in end-stage kidney disease. These people, adults, will be asymptomatic until the age of somewhere between 30 and 40. When they start showing signs and symptoms would include abdominal pain that worsens with activity, relieved when lying down, fevers, chills, frequent urinary tract infection, hematuria, proteinuria, pyuria, calculi, hypertension, palpable masses, they get so big, and increased abdominal girth. Nursing interventions, monitor for the hematuria, because when the cysts rupture, that's when there's even an increase in the hematuria. Increased sodium and water intake because of sodium loss rather than retention. Provide rest. Avoid NSAIDs. Make sure to prevent constipation. They may be on stool softeners. Antihypertensives. Treat the UTIs. Assist with preparing for dialysis. Encourage genetic counseling, psychological support as well. Okay, well, that's all, folks.